I think sometimes people don't expect pediatric patients to handle radiation as well as they do. They may have a family member who also had radiation for breast cancer or for prostate cancer, and they were an older adult and had really severe side effects. And then they say, oh, no, I've got to put my little baby through this. I don't really want to do this. So we actually say, well, kids are very different in how they handle this. They're very resilient, so we can provide good education about that.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello, and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Elizabeth Cummings, Radiation Oncology Nurse Practitioner at Children's Hospital of Philadelphia in Pennsylvania, about radiation treatment care for pediatric patients. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the notes. Welcome, and thanks so much for joining us today, Liz.
Thanks so much for having me.
So to start things off, can you just give us a brief overview of the history of radiation treatment and the use of it with pediatric patients and how that has evolved over time?
That could take a long time, but in very broad strokes. X-rays were first discovered in late 1895, and within months, there was pretty broad application of that for clinical uses, both diagnostically and with therapeutic purposes. And in 1896, we have the first reported case of breast cancer that was treated with X-rays. Of course, that was in adults. But in the early 1900s, radiation, especially X-rays, were used for a variety of childhood ailments, such as pertussis, mumps, endocrine issues, meningitis. I mean, there was just a lot of things that they were trying it with. But moving into pediatric oncology, before the 1960s, surgery and radiation were really the mainstays of pediatric cancer treatment. We used large fields. There were high doses. There's a lot of normal tissue in the field. There was really a limited understanding of the long-term effects of radiation on developing children. But our top priority at that time was survival. Kids were getting diagnosed. They just didn't have a lot of options. So we really were just, what can we do to help our patients survive? And then kind of moving into the 1960s and then through the 1980s, we see the introduction of chemotherapy. And that was, of course, a game changer. And we really found that by combining these therapies, that helped to improve survival rates. So I think especially ALL and the Wilms tumor. And by adding chemotherapy, we found that we could actually reduce some of the doses of radiation. And that in turn helps with the potential long-term complications, which at that point were just really kind of starting to be identified. They're starting to see, these kids that they had treated earlier. Now we're starting to see some of this developmental issues, secondary cancers, these things were coming about. And then moving into the more modern era, the 1990s to the present, it's more of this era of precision medicine and more targeted therapies. So we're seeing just advances in technology. We have much improved imaging, being able to plan on the computers. There's also just a much better understanding of tumor biology, which has helped us to tailor treatments based on that risk assessment. For favorable histology tumors, now we have molecular information that says, hey, this is a much lower risk. We can tailor a therapy and we can say, you probably don't need as much radiation as somebody who is in this higher risk. And then we've also just seen a lot of improvement in our techniques and also in the treatment delivery. So intensity modulated radiation therapy is very different from the very beginning when they were doing kind of a point and shoot and this 2D. And now we have protons and IMRT, and these things help us just to be a lot more conformal with our radiation. So the aim of our studies now are really, how can we reduce the doses of radiation and how can we make our field smaller? So we really want to just be more conformal, and that helps to just limit the amount of normal tissue that's in the radiation field.
Well, thanks for that great overview. And you're right. It's kind of a big and unfair question to ask you to quickly summarize the entire history of radiation. But what I take from that is, as a clinician focused on adult patients, that the general history is not that much different from pediatrics versus adult, but the way that it's applied, the indications and the diagnoses that are seen more often in pediatric patients, and so everything that's associated with that can be very different. And so I'm excited to talk more about some of those differences in our discussion today. Moving on to that, let's talk about some of those side effects that pediatric patients might experience from the radiation treatment, which again is probably rooted in why are they getting the radiation treatment? What is their diagnosis? So what are some of those typical side effects that the pediatric population might see that maybe is a little bit different than adult populations? And how can we as oncology nurses help to kind of address those side effects and mitigate those concerns?
So radiation side effects, we really think about in two categories. The acute side effects, those are the things that occur during radiation and for a few weeks after and tend to be more temporary. And then the late side effects, which can develop years after treatment and may have more permanent or lasting implications. Because radiation is a focal treatment, we're really thinking about what area of the body are we treating. And the things you really want to also consider are the size of your field, how much dose is being delivered. Is this a low dose? How much is the dose per fraction? Are we doing this in, standard, or is this something that we're treating in a larger dose per fraction? Are they getting chemotherapy at the same time? A patient with Ewing sarcoma who's getting interval compressed chemotherapy every 2 weeks, they're dropping their counts. You're going to see probably more a significant skin reaction. Is this an initial course of radiation, or is this a second course of radiation to the same area? And then really, as we're thinking about late effects, kind of how old is this patient? If we're treating the brain of a 3-year-old, that's very different from treating a 17-year-old. And I always like to point out, kids are very resilient, but they do potentially have this longer life ahead of them. It's different to treat a 60 or 70 or 80-year-old than somebody who's small, who you think have a chance of cure, but now they have a lot more years ahead of them to live with those late effects. So just thinking about the acute effects, it's very similar to adults. You can see some hair loss in the field, headaches, nausea, vomiting, changes in vision. When we're treating the head and neck, you can see a little bit more with the dry eyes and nasal congestion, maybe some nosebleeds, sores in the mouth, sore throat. When we're treating the abdomen, maybe more nausea, vomiting, some diarrhea, maybe have decreased appetite. When we're treating the bladder, you can see some pain with urination or blood in their urine, bladder spasms. And if the rectum's in the field, then they can have just a lot more irritation there, and they can actually start withholding stool. So I think one of the things to think about with kids is sometimes they're not as forthcoming with what's going on. And sometimes it's a little bit harder to understand, sometimes that's just developmentally because they're much younger. It's 1-year-old can't exactly tell you what's wrong. And so you're really trying to kind of figure it out based on their cues versus, maybe a teenager who can tell you, but maybe they're too embarrassed about something in a way that maybe an adult might not be. And I think nurses play a really important role in this. They help to just provide a lot of anticipatory guidance about what to expect. Much like in the world of transplant radiation, there's often a pretty predictable timeline about what side effects to expect when. And it really helps patients to know what's coming. Nurses can also really just make sure that they have the medications they need for that management. I mean, the medical team is doing that, and the nurses are also the ones that are often seeing them a little bit more frequently and building up that rapport. Nurses are really good advocates for the nutrition support and just helping to reassure parents regarding what to expect. Parents are a huge part of the equation in the pediatric world. So just making sure that they're kind of both involved and also allaying some of their anxiety is really important.
Yeah, you bring up some really, really important points that, again, as focusing on adult patients my entire career aren't necessarily things that I actively had to consider of can my patient communicate with me what is wrong or how they're feeling, or will they listen to me if I tell them what they need to do? And as you mentioned, the parents are probably just as much the patient as the child is.
That compliance can be a big thing to it, like you said.
Absolutely. And you mentioned nutrition. So let's dive in a little bit about that. Talk to me about the importance of nutrition support for these pediatric patients as they go through treatment. And how can oncology nurses help to ensure that they're kind of getting the support that they need?
So nutrition is so important. You think about some of our patients, they can be very small to begin with, or maybe they're picky eater to begin with. And now we've just added more challenges to that experience for them. So we really do monitor the weight very closely. Now, the anesthesia patients are getting their weight every day. For a non-anesthesia patient, that is going to be once a week, but we may say, actually, we want to check it 2 or 3 times a week. And we find that we really have to ask very specific questions, such as, what have you had to drink so far today? I find that sometimes we say to a patient, did you drink enough? They say, yes, but you really want to kind of quantify that. Even things like, how many times did you pee? What color was your pee? It's really helpful. It's also by assessing for the symptoms such as nausea, or finding out that they have decreased appetite, or finding out, they're having some pain when they're swallowing. Those things can all affect their oral intake. So just trying to provide the supportive care that they need in order to make them as successful as possible. We also have a fantastic team of dietitians. So we may say, hey, let's loop them in early, knowing that this is a patient that is likely to struggle. There's also sometimes when we will advocate for having an NG2 placed or even for a G2, if we're treating something in the head and neck, we know it's going to be 6 or 7 weeks of treatment. This patient is already a picky eater. They're not very motivated to, ensure that they're taking in enough. Maybe they've already started out underweight, then we're going to be a lot more proactive. And part of all of that, of course, is just educating our patients regarding what to anticipate in terms of the radiation side effects and making sure that we're providing the supportive care.
It's also important, especially, asking those specific direct questions. We fall prey to that as well. And in the adult world are you eating and drinking okay? Yep. Okay. Well, that doesn't tell us how much, what type of things that they're consuming. I remember I asked a patient similarly, I'm like, are you drinking enough? Yeah. What are you drinking? Kool-Aid. Okay. Well, that's why your blood sugar is 300. So again, like details matter. And as you said, especially when we're dealing with pediatric patients or young patients, of just getting into the specifics. It's so important. So thanks for bringing that up. Talk to me a little bit about child life specialists when we're caring for pediatric patients. How do they get involved and what assistance do they provide to both patients and their families?
Child life specialists are incredible. I think we'd be so lost without them for sure. They are vital. They provide age-appropriate education and explanations for our patients. So talking to a 3-year-old about cancer is very different from an 8-year-old or even a teenager. And so they really are able to just meet each patient exactly where they are and at the level that they are, and provide the appropriate amount of information, which is so helpful for patients since they learn to just build trust and cope with their treatment, just to feel like they have somebody who can relay that information in a clear and concise way. They also provide a lot of procedural support. So our patients who are receiving anesthesia every day, most of them have a port, so they need their port access to that's once a week. And so they'll provide the support for that. And then also for patients who are not getting anesthesia, they need to come in for simulation, which can involve that mask, making the mask to hold their head in place for treatment. And then, that can be really scary for a little kid. So they are present for that. And they help to explain to patients what's going to happen and then provide support in the moment as those things are happening. And then, of course, when the patient comes back to start treatment, they are also there to, again, advocate for them. They can talk them through what to expect. And by having that support, that can often decrease the need for general anesthesia. For, patients who might be a little bit on the fence, just that extra support can go a long way. They also provide psychosocial support throughout this whole, journey of hair loss. And maybe they're really anxious, they have a lot of fears, or they can also do some therapeutic activities. Patients can get really angry. They have cancer. They aren't like their peers and they need an outlet for that. And so they can do, exploding volcanoes and other things like that. And just in so many ways, they just help really promote resilience with our patients. They can also do medical play. They also provide support for siblings, and they just also do a really nice job of developing rapport with patients, which can help to facilitate communication even with the medical team. Sometimes because they're spending time with the patient may, say to them, and actually, I didn't want to tell anybody this, but I have this symptom, or maybe it just comes up in their conversation and maybe the patient isn't as comfortable saying that to the medical team or even to their parent. And so they can help to just ensure that the medical team is looped in about that. And they're a nice liaison between everyone.
That sounds great. And what a special role for those members of the team and so much support they provide. Maybe we need to have adult life specialists.
Yeah, exactly. We've said that a few times in our adult side. Right? We have one of those for our patients too.
I mean, again, everything that you mentioned seems like it would also be helpful to any patient. So that's great. But it's great that role is there to support children and their families as they're going through such a challenging ordeal. Now, you mentioned a couple of times about the anesthesia, and so I'd like to just maybe pause and talk about that. Explain to me the use of daily anesthesia for patients or for pediatric patients, and what are some of the considerations or risks that we as nurses should consider as we care for these patients?
Patients who are really small will need anesthesia every day for the treatments, not because it's painful, but just because they can't stay still for treatment. And so our goal is to use as little anesthesia as possible, but we also have to be able to deliver this treatment safely. One of the significant challenges is just the NPO restrictions around that. If you're getting anesthesia, you can't have anything to eat for 8 hours before. You can have clears up until an hour before. But for small children, one, you have to keep them NPO. You can't just ensuring they don't have access to food. And then also making sure that they have that nutrition adequate calorie intake during this time when they're essentially, missing a meal every day. We would, of course, love to treat every patient at 7 a.m., but obviously we have more than one patient at a time. And so there's some patients who are getting treated a little bit later in the late morning or the early afternoon. And so we should just ensure that they're still getting the nutrition that they need to. As nurses, we try to, advocate for who needs to be in the early slots just to support that nutrition, as well as just keeping that, again, a close eye on their weight and such. The other thing we think about with anesthesia, sometimes you can have nausea or vomiting after anesthesia, although it's not common. Usually we'll give a dose of Zofran, and that really helps to minimize kind of any anesthesia effects. There are a very small number of patients who could develop emergence delirium, and so the nurses are really pros at assessing that out. And just, when you're getting anesthesia every day for 6 weeks, you really have to be able to adjust the plan and try to kind of come to a place where patients are able to have good wake-ups throughout that process. At different centers, we may find that they use different types of airways. There can be some centers that use a natural airway, so they're not really putting anything in the mouth. Others will use something that's kind of just holding the tongue out of the way. And there could be some centers that are doing that true, like full intubation. And so depending on sort of what type of airway, you could see different side effects of that. Somebody who's getting fully intubated every day, you're going to have, a lot more irritation to the throat and to the vocal cords. And so the nurses are going to be the ones that are going to be monitoring that just because they're seeing these patients every day. During viral season, that can also present some challenges. Radiation treatment's not something elective, so we can't say, well, you have a little bit of a cold today, we're just going to cancel this. We'll reschedule you to next week when you're better. We really have to take into account that the radiation that they're giving is life-saving treatment. But we also want to make sure that we're not assuming too much risk. So it'll, of course, be up to the anesthesiologist as to whether they feel it can proceed safely. But really, our goal is to minimize cancellations. And so we really want to provide the supportive care that we need to try to keep going with radiation as consistently as possible. It's also possible that you could see some complications from having a central line. They could develop a clot, or you could have some sort of infiltration. So the nurses, again, are going to be assessing that and monitoring for that. I think one of the things that's really in the news, so to speak, is considering the risk, the long-term impact of general anesthesia every day. And the truth is, right now, I'm not aware of any studies that have evaluated daily anesthesia for 6 weeks and kind of the late long-term cognitive impacts of that. There's certainly growing concern about the potential effects of anesthesia on brain health, especially in really vulnerable populations, such as the very young children, which are the ones, of course, who need anesthesia. But we really try to mitigate this by optimizing our anesthetic agents. So we'll use propofol, which has a really quick onset and offset. And, even when the radiation treatment is done, they'll stop the propofol in the radiation room, even though they are still walking back to recovery, just to minimize the amount of time that it's on, and trying to use, again, the lowest dose possible. We also do a lot with just exploring those non-anesthesia strategies. So child life support, just trying to introduce video distraction when we can, having music, audiobooks, anything. So a kid who's, 5 or 6, they may be able to do it without anesthesia. And of course, we like to advocate for that.
Those are all just very important things to consider. And, it highlights that the risks that come with treatment aren't necessarily directly from the treatment. Sometimes it's those supportive therapies and adjunct things that would have to be included to support the delivery of the treatment, but there are potential risks and things to consider with that. So I think those are important factors for nurses just to be aware of and to consider for all patients. So kind of switching gears here a little bit, what factors do you think healthcare professionals should consider when they're balancing maybe curative treatments versus maintaining quality of life in pediatric patients that are undergoing radiation therapy?
It's tricky in the pediatric realm. You have the patient in front of you, as well as the parents, as well as, family values to consider. Sometimes we have very clear recommendations because there's a protocol, things are very standard. We say, this is what we need to do for curative intent. Sometimes there can be areas that are a little bit more gray. My probably best example is a 4-year-old with medulloblastoma. We would say for an older patient, the standard would be whole brain and spine radiation would be our approach, and we would do radiation first. With a patient who's 3 or younger, we would say, no, we're going to lead with high-dose chemotherapy because we know that the toxicity of radiation to the whole brain and spine of somebody that young be just really toxic. So now you have a 4-year-old. They're kind of right in the middle of this. They're more than 3, but they're less than 5. So which direction do we go? Do we say we recommend chemotherapy first with high doses, knowing that if we lower the likelihood of cure is lower, versus do we say, no, this is cure at all costs. We're going to do this whole brain and spine radiation, but there is going to be a lot of toxicity from it. And so a lot of times in those situations, it really is a conversation with the families and kind of identifying sort of which approach they are considering. Now, I once had a patient who came to us who had lost vision. And this was, again, prior to, these are a result of surgery. So they came to us, who was already blind, and the radiation that we needed to give was going to put him at risk of hearing loss because he needed whole brain and spine radiation and then a boost to an area that was really close to his cochlea. The parents said, hearing is going to be so important because he can't see. At this point, really, we would rather accept some risk by providing less coverage to that area around the cochlea. So we want to spare the cochlea in favor of preserving his hearing, because cure at all costs, if he's blind and deaf, like that is a very different scenario for us than if, we're able to preserve that hearing. So I think that, it's so important to just understand that where the families are coming from. There are, of course, times when we may not be able to do that, but this is where I say medicine is a little bit of an art as well. Yes, we have this answer from science, but we're caring for people. And so it's important to understand what their priorities are as well.
That's so important. And thank you for sharing those examples. I think really highlight the complexity of those decisions, not only for healthcare providers as us to provide those options, but for patients and their families to make that choice. These are sensitive cases. We see that across, no matter the age. If somebody has cancer and it's a life-threatening illness, things get tricky. So what sort of ethical guidelines or sort of ethical support do you see or do you often use, not only for patients on regular treatment, as you've just described, but what about also when they're considered for a clinical trial?
Well, I think when we're involved in clinical trials, I think it's really important to try to remain impartial. Sometimes I can get really excited about a trial and think, oh, I think it would be so great. We want to really understand if this particular dose of radiation is going to be the thing that is helpful. But that ultimately, it's a clinical trial. We don't know what the results are going to be. And so we want to ensure that we're not really pushing patients and parents into something just because that's what we think might be best. So trying to just remain impartial, ensure that they have all that information provided, that the trial, that they have comprehensive information, that it's understandable to them, that they really have time to digest it, to really think about it, to talk about it with their families, to talk about it with their oncologists, just to get a second opinion. As nurses, I think it's really important that we're just monitoring for toxicities and managing them appropriately. Sometimes it's tempting to say oh, is that really a grade 3? Maybe that's only a grade 2. And so just trying to be as, impartial about that and reporting it accurately. And then just reminding, patients and parents that participation, if it's a trial, that's voluntary. And just remembering too that pediatrics, the patient, not the parent, is your patient. And so that can look really different for a 3-year-old versus a 17-year-old. Somebody who's, they can't officially sign consent, but they certainly have a lot of buy-in about the things happening to their body versus, a 3-year-old who the parents are really taking ownership of that. I think sometimes it's tricky in the world of pediatrics, just to be, as we think about the ethics of who are we treating here? Is it the patient? Is it the parent? And we continue to advocate for our patients.
You mentioned earlier a little bit about some of the sort of late and long-term toxicities. So let's dive into that a little bit more. Can you explain some of the late toxicities and potentially even secondary malignancies that we might see in pediatric patients after they experience radiation treatment as a young child?
In pediatric patients, I think one of the things that really makes the late effects significant is that their tissues are still growing. Maybe a 3-year-old still has a lot of growth ahead of them. So the tissues that are in the radiation field, they're not going to grow quite the same way as if they had not seen radiation. So if a young patient, we're treating their spine, those vertebral bodies are not going to grow quite as much, and they may have a shorter sitting height. Versus if we're treating something on their face, they can develop more craniofacial abnormalities depending on the location. The other really challenging late effect can be cognitive changes. Again, it depends on the age of the patient when you're delivering this treatment, but they can have short-term memory problems. They have more trouble acquiring new information, maybe a slower processing speed. Again, depending on the area of the brain that was treated, if it's whole brain radiation versus something focal. We can also see endocrinopathies develop as the pituitary stops working. That's not something that you would see right away, but can be a few years in the future to, many, many years in the future. So they're going to just be followed by an endocrinologist for a long time. You can also see changes in vision. So they may be more susceptible to developing cataracts, same type of cataract that your grandmother gets, but this would be at a much younger age and usually just results of exposure of the lens to radiation. They can also see high frequency hearing loss. There can be dental issues, some oral cavities involved. So they can be more susceptible to more cavities. Maybe their teeth aren't growing in. Generally, they can also have impaired bone health if there's particular bones in the field. So if we're treated the sacrum and then they are in a car accident and, there was a lot of force in that area, there could be an increased risk of developing a pelvic fracture. Patients can also be more at risk for heart disease. So the radiation can age the vessels prematurely, and that can increase the risk of stroke. If the lungs are in the radiation field, we worry about developing pulmonary fibrosis or restrictive lung disease. If it's the bladder, we can see decreased capacity of the bladder, so they have to go more frequently, or they may just not be able to hold it in the same way. You can also see some alterations in bowel habits. And, if the intestines are in the field, but also we worry about infertility or secondary malignancy. And the secondary malignancy can be anything from a skin cancer, which is generally non-melanoma. It's a squamous cell. It's something that can be removed in the dermatologist's office versus something more significant, such as a sarcoma or breast cancer or colorectal cancer.
Well, and as you alluded to earlier, the course of their late and really their long-term side effects, their length of their survivorship is ideally very long. If they're getting treatment as a young child, we hope that they get 50, 60 more years, but that comes with concerns. So what are some of those survivorship concerns that our pediatric patients might face after receiving treatment so young?
Survivorship concerns depend on the area of the body that was treated, as well as the age of the patient when they were treated. So if we've treated the brain, you can see cognitive changes and challenges, which can really have a lot of implications for their psychosocial and career and just how they relate to their peers. So we will usually recommend neuropsych testing. We try to get that baseline and then have that done periodically and over time so that we can try to capture that early and intervene quickly and just try to minimize the impact of that on their life. For, those endocrine issues, they very well may need to be on replacement meds. Thankfully, that is something that, everything can be replaced by a patch or pill, but it is something that we'll need to follow really closely. And so we'll recommend in survivorship that if the pituitary was in the field, that they check endocrine labs, every periodically as dictated by the survivorship guidelines. Usually it'll be every, 6 months to a year. Again, that's something that you would probably see in labs before you would necessarily notice a clinical change. As far as dental issues, the dental stuff can get so expensive. So we will counsel patients, keep your dental insurance really for the rest of your life because these things can add up. And again, we just want them seeing the dentist regularly, frequently, and just trying to intervene early. As far as bone health, because there can be an increased risk of fracture, so the bones that we've treated, we want to just consider what are the most appropriate activities to participate in. As far as hearing, close audiology follow-up, just to ensure that speech is developing normally and that they have good auditory processing. For heart disease, we really want to promote a heart-healthy lifestyle. So we really love to encourage patients to, find something active that they enjoy that they'll continue doing. There would be swimming or biking or dancing, whatever it is, just they're getting their heart working. It's one of the best ways to promote that. And also just keeping in mind, kind of a good diet so that they're trying to kind of keep their heart in the best shape as possible. As far as lung health, we'll encourage them to limit environmental exposure. So we say, you're not smoking now, don't start, don't vape. We really want to keep your lungs as pristine as possible if your lungs are exposed to radiation. As far as urinary symptoms, it's really just trying to, again, mitigate. So you've decreased bladder capacity, just learning how to manage that, especially in potential social situations. So just trying to kind of ensure that. And of course, you can always refer them to urology to see if there are things that can be done to promote that. As far as fertility and infertility, we will sometimes set up either, a consult with our fertility team before radiation starts. With protons, it can often help a lot just in terms of minimizing any radiation that's going to those organs. But we also know that sometimes it's unavoidable. And so men may sperm bank before they start, our young teens. For females, sometimes there's an option where they can actually do a surgical procedure, move the ovary out of the field if it wasn't compromised, and then they'll put it back once radiation is done. So those are just, things that we'll certainly try to explore up front. And then we can come to a reproductive endocrinologist as well to help with managing the hormone aspect of things. And then as far as second malignancies, we'll just encourage screenings. So the Children's Oncology Group does have a set of guidelines as to when to begin screenings. Those will be updated. So just based on the current recommendations, they need to start screening for certain things earlier. And we really do encourage that. We want to catch things as early as possible. Although, of course, we don't want to certainly add added anxiety, but just by kind of having those regular screenings that can help to do that. I do like to just kind of point out that, the historical survivorship data that we have, it's really based on older forms of treatment that we don't use anymore. So there's really quite a bit of data lag in terms of as we predict risks. It's really based on older technology. Recently, I had a parent who came to me and she said, my neighbor recently died, and this is what her obituary says. She died at age 65 due to late effects of radiation treatment that she received at age 19 for Hodgkin's disease. And so kind of did the math and I said, okay, well, she was treated back in 1978. The treatment that they were using then was really different from what we're using today. It was a very large field. They didn't sculpt it, got much higher doses. Your daughter is not in the same position that this woman was, just because the technology has advanced. We have newer techniques with our computer-based planning, just being able to sculpt the dose, all the advances in therapy, having protons. All of these things have really led to less radiation to the healthy tissues. And we've also seen a lot of improvement in the systemic therapy. And so both of these things are really going to help to minimize some of those survivorship effects.
That's such an important example, just highlighting how we have to kind of understand where our patients and their families, their parents, their caregivers, what information do they have? How is that driving their concerns or their fears, and being able to ensure that they're operating off of current information so that we can hopefully address those things and inform them of what is new or accurate or different. And so a great example to share there. Well, Liz, as we reach the end of our podcast, thank you so much for coming and sharing all of this great information about pediatric radiation, just some of the things that we should consider. And I know that I've certainly learned a lot, and I'm sure our listeners have as well. As we get to the end of the podcast, we'd like to always run through a series of just some quick questions to help summarize some of the great things that we've talked about today. So to start that off, how do you think we as healthcare professionals should evaluate maybe our hidden or implicit bias about radiation treatment care for pediatric patients?
I think some of the most common ways that I see it in the world of radiation is just considering in the modality of treatment, what type of treatment are we using? Is it worth it for this patient? As well as kind of the bias that can come up in palliative situations. So sometimes you have a patient who's coming, they're getting palliative radiation, they're really sick. Maybe they're even at the point of or not expecting them to live much longer. And yet here they are coming for radiation. And so sometimes we kind of say, like, what is going on here? Why are we doing this? Are we just treating the parent? Are we really doing this for the patient? And sometimes I have to take a step back in that and just look at the whole situation. This patient is having a lot of pain and radiation can help that. And so that is a reason to do this. And this is something that can provide good pain relief for them. Whereas other times when maybe we say, like, we want to do everything for this patient, is this really the right thing for them to, be put under anesthesia to deliver this treatment when maybe that's really not aligning with the goals. And so just kind of taking a step back and thinking about those things and what modality we're using. We will sometimes still use protons for a patient, even if they relapsed and now they need spine radiation, but they can live for 6 months and protons are going to spare them from a lot of nausea and vomiting. Then yeah, it makes a lot of sense to use protons for that.
What are some common misconceptions about radiation treatment care for pediatric patients?
I think sometimes people don't expect pediatric patients to handle radiation as well as they do. They may have a family member who also had radiation for breast cancer or for prostate cancer, and they were an older adult and they had really severe side effects. And then they say, oh, no, I've got to put my little baby through this. I don't really want to do this. So we actually say, well, kids are very different in how they handle this. So they're very resilient. It's not going to be the same experience that grandpa had. So we can provide good education about that. Another question that can come up from parents is my child safe to be around? Is the radiation making them radioactive? I'm pregnant. Can I still hug them? Can I still kiss them? You say, yes. Your child is completely safe to be around. And another one that can come up is radiation painful? You're putting people to sleep to get this treatment. Does it hurt? You say, no, it's not. The delivery of radiation, it's not painful. It's just this patient is so little that they can't stay still. So you need anesthesia.
What's something about this topic that's not often discussed, but you wish people knew more about?
I think that pediatric patients still want to be normal kids. They still want to do their normal activities. I think also just kind of touching again on that resilience that our pediatric patients, a lot of times they have healthier tissues. They haven't seen as much wear and tear. They haven't developed bad habits. So some adults, they don't have the same environmental exposures. They're not smoking. They probably have fewer comorbidities. So probably don't have heart disease and, they're not obese and these things. And so they're just a different population. I just really commend them. Sometimes we think about putting adult patients through the things that pediatric patients are going through. And you say, I would never survive this in the same way, like the way they're doing. They're just amazing. They still want to be a kid. They still want to do they still want to go to school. They still want to be with their friends. It's really encouraging to see that.
What additional training or education do oncology nurses need to stay current on this topic?
There's always new information coming out. So just staying abreast of new trials, modalities, participating in webinars and podcasts and attending conferences. I think those are just always to kind of stay current with things.
And what are some additional resources for patients or maybe even other healthcare professionals who want to learn more?
Our institution has something called OncoLink Junior. So OncoLink is kind of our education forum, but then OncoLink Junior is geared towards pediatric patients. I think there's other radiation centers that have really robust and high volume pediatric programs. They also have similar resources. There's a Pediatric Radiation Oncology Society and some of these other pediatric organizations. They can provide a lot of their good resources.
Well, Liz, thank you again for coming on the podcast and sharing all this great information about pediatric radiation and just helping keep us well-rounded and all the information we know. So I really appreciate your time and sharing your expertise. Do you have any final comments you'd like to share with our listeners today?
Technology continues to improve. So we're continuing to see changes. More and more proton centers are being built. So they're becoming more widespread, which is great for our patients just to have access to that. And also flash radiation. There's a lot of buzz about that in the news, which is a type of radiation that's delivering ultra high dose rates. And the idea that it'll provide benefits like reduced side effects and improved tumor control can do this in a fewer number of treatments. So I think that hopefully in the near future, in the next few years, that'll start to become a reality. And that'll really be life-changing for patients, because instead of 6 weeks of treatment, this is something that can be done in maybe a week. And so that's just going to be something that'll be really incredible if it happens. So I think just staying current with the things that are being offered in terms of therapy and staying in the know. It's great.
Great advice. Well, thank you again, Liz.
All right. Thanks so much.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.